We are live now.
Yeah.
Perfect. Welcome everyone. We're just going to give it a minute and just wait for people to sign on. Thanks for joining us this evening. Just give it a minute. Great to see all the numbers coming in.
Yeah. It's increasing, like.
Yeah.
Yeah.
Okay, guys. All right, I think we'll just kick off. So I'm Aoife, and I'm going to be in the background just answering any kind of queries you may have. This is Dr. Ayesha Mir, and she's going to give the presentation this evening. Ayesha is based in our Cork clinic. If you have any questions or anything like that, please just pop it into the Q&A box, and Dr. Mir will answer them at the very end. Okay, so I hope you enjoy your webinar tonight, and I'll hand you over to Dr. Ayesha. Okay.
Thanks, Aoife. So a very warm welcome to everyone here. So I am Dr. Ayesha. I will be talking to you about the general overview about fertility, its causes, the treatments, the investigations, and the different treatment options and the testing that we offer here. So I will just start doing my presentation now. So it will be very simple. I have made it very simple so that everybody of you can understand it. And if you still have any questions, you can put up your questions and we can answer them one by one. Okay, so we'll just start with the presentation now. So a very warm welcome to everyone here. So first of all, I will just discuss and what I'm going to discuss today. So we will discuss first of all that what we mean by infertility, what are the main causes for it, and what are the investigations or the testing that we start with before we decide for any of the treatments that we need to offer you. And then we talk about the treatments in very short details that what are the different treatment options available here. So what is we actually mean by infertility? So by definition, what we mean is that if you're not able to conceive after 1 year of trying, and if you're less than 35 years of age, we always recommend that you start your investigations and start testing for it after 1 year of trying. And if you are more than 35 years, preferably you should start investigating after 6 months of trying. So what is the incidence of subfertility or fertility? We have that every 1 out of 5 couples can have this problem. It can be either primary or secondary. That means primary, what we mean is that you have not been able to conceive even for once, and by secondary means that you have been able to conceive before by natural conception, but now you have been struggling to conceive. So there's a slight difference between the infertility and subfertility. Infertility basically means that you have not been able to conceive initially without no previous conceptions, and by subfertility means there's a slight bit of problems that you're having before you had the conception. And also, it has to be a reproductive choice for some couples, like the same-sex couples, where you this is the only option for you to go for the conception. So by what we mean by the likelihood of pregnancy, if you just see a graph here, so it is just showing that why we have used a cutoff of 1 year that you start investigation after that. So if you just see that the cumulative or the increased conception rates just start when you start conceiving from 0 1, and it just goes on to the rates of increased or the likelihood of increased chances of getting pregnancy over a period of 12 months time. And then if you see after 12 months, it just goes to a static line or a plateau line, but it just remains the same after that. Okay. And if you just see to the monthly conception rates, it just starts decreasing or over the period of months that you have been trying to conceive. And after a period of 12 months, if you see a pink dot here, it just goes to a static line. That's why we always say that the cutoff is usually of 1 year, and you should start investigating and start looking for your options if you have been struggling with that. So this is a very important slide that you should see here. What we mean by a biological clock. So that means that every person, be it a male or a female, the age does matter for both the partners, be it a man or a woman. So if you see a graph here, there is a rapid decline in the fertility, for especially for the females, if you go from an age of 20 to 45 years, which is a reproductive phase for the woman. So the most fertile period is between 20 to 25 years. And then if you see that if you reach the age of 35, the fertility potential is almost half to that of what you had at the age of 25. And then it also further decreases if you go beyond the age of 35, if you reach the age of 40, it further decreases. So that means that if you go from an age of 25 to 40, the fertility potential has almost decreased to this much. And after 46 years, potentially there is no eggs left as you go through the period of menopause then, and there's no eggs left that could give you the fertility potential. So most of the ladies usually have about 40% of the women here have the first baby around the age of 30 to 35 years. And because it's different times that we are living in, and now we have different options for the fertility potential and for the timing of the pregnancy. This is a very important thing to consider that age is the most important factor regarding the fertility potential. So now we will talk about it. What are the main causes that we actually look into that we investigate, and which are the things that we need to look into when we talk about the investigations or when we talk about the treatment options available. So there are mainly three factors that actually lead to a pregnancy. The first is the egg. So for egg, both the things matter. The supply, which is usually called as a quantity, as we have discussed in a previous slide, that the potential for the egg reserve decreases with the age, that is the supply. And also very important thing is that not only the quantity of the ovarian supply or the eggs, the quality of the eggs also decrease with increasing age. And the second factor that we have to talk about is sperm that comes from the male side. So the most important thing is count. Then the motility, which is the number of motile sperms available. The motility is very important. We'll discuss in the later slides that why it is very important from that point of view. And morphology is the shape or the anatomical structure of the sperm that is again very important. So all these three factors count for a good semen sample to make sure that you're able to get pregnant. And the third thing is the housing, or we call it as uterus. The uterine cavity is the place where the embryo has to implant and where the implantation has to take place for the pregnancy to grow in. Fallopian tubes is important if you're looking for a natural method of fertility, or if you're looking for a non-invasive methods of conceiving other than the IVF, because tubes are very important. They act as a source where they have to travel from the ovaries to the uterus to reach the sperm. And then the implantation process is very important because there are different factors in your womb lining that actually hamper and that actually favor the process of implantation of embryo. If you look into this pie chart, so we normally categorize the causes of the infertility into 4 or 5 main factors. So the male factors count for almost 30% of the couples which have the problem in conceiving. The female factors count for the similar rate of about 30%. The combined factor is in about 10% of the couples. And unexplained, if we just look into that, unexplained means that we have investigated every thing related to both the male and the female partner, but we could not find any reason for their reasons of not conceiving naturally. So this group makes a very important group because this is the group that we normally offer with IVF methods of conceiving because we could not find any other reason for that we could correct. So IVF could give us some better chances for them for conception and also to find out the reason related at very minute details about the egg quality and the sperm quality. So this is the clinical course that happens in our clinic. So the first stage is the consultation with the doctor. The second stage is to do the testing, like the scans and the investigation, which are usually the blood test and the ultrasound scans. The stage three is the drugs which we actually use or the treatment protocols that we use to help you with the process. This is usually in the form of IVF, ICSI, and some other non-IVF methods like IUI, which I will just discuss in detail with you. Stage four, it is only showing here about the IVF, which is related to the egg collection. Stage five is where we make the eggs and the sperm meet together to make the embryo. Stage 6 is then you have the transfer. Stage 7 is that you have to wait for 2 weeks because the embryo gets a bit of time to implant. We call you in a 2 week time to get the pregnancy test. And once the pregnancy test becomes positive, then we refer you to your stable. So now we will talk about that what are the investigations or what are the testing that we actually do to proceed with our proceed for any treatment plan later on. So if you just look around here, so the female organs, as I already told you, these are mainly three main organs. The ovaries, which are the reservoir for the eggs, the tubes, which are the conduit for the transport of the eggs from ovaries to the uterus, and then third is the uterus. So all investigations and everything relates to checking for these organs. And there are a few other hormones that play a very important part in the menstrual cycle and the ovarian cycle in other parts of the body. So one of them is the prolactin, which is one of the hormones released from the brain, which we actually check. Another one is in the thyroid gland, which plays a very important part in the menstrual cycles, and that is also being tested. And there's another hormone which is usually called as male hormone, that is testosterone, but it also plays a very important role in female menstrual cycle, and it's a very important role on the quality of the egg, that is also being tested. So if you talk about the male organs, so there are three main organs. So these are the testes, which are the main source of production of sperm. These are the tubes which actually transport the sperms from the testes to the glandular organs, which we call as seminal vesicles. They reach here, and from there they go through small tubes to the penis from where they're delivered. So first, we'll talk about the male testing, which is the semen analysis. So we check mainly three important things in the semen sample. The first is the number. So the number should be at least more than 50 million, preferably more than 20 million. The second thing is the motility. So the number of motile sperms in any sample should be at least more than 40%. And the third thing is the morphology, that is the normal shaped sperms, which should be at least more than 35%. Okay. So then the second test that we sometimes offer is for the male partner is DNA fragmentation. So this is not the preliminary test that we offer for all the couples. The only thing the first thing first is the semen analysis. But we also offer DNA fragmentation for those couples. It's only indicated in those situations when there's unexplained infertility, when the sperm sample is all good, but the couple is not being able to conceive. The second indication could be when there is recurrent implantation failures or recurrent miscarriages for a couple. The third thing could be that if there is a chronic condition the male partner is having, like diabetes, and also if the couple has been through an IVF or an ICSI cycle before, but there has been a poor development or a low to average development of an embryo, then we can also do a DNA fragmentation test to see if there's further damage to the sperms or not. So this will give us further information about the semen sample. So now for the females, as I already told you, that there are three main tests that we normally do for the females. One is the blood test. So the blood test, as I told you, is for a few of the hormones that we check. Anatomical testing is to check for the uterus and the tubes. And the other tests include further fancy tests, which include testing for the immune environment of the uterus, which I will just discuss in detail. So the blood test, as I already told you, it's thyroid function test and also for the thyroid antibodies, which play a very important role in the fertility potential for any woman and also play a very important role in women who have recurrent miscarriages. So we always test for that. Second is the prolactin. The third is the full blood count. The fourth is the testosterone. Fifth is the rubella. So we always make sure that the woman is immune to rubella. If not, you always need a vaccination before you start your treatment cycle. The fifth is the thromboelastography. This is the test to detect that about the clotting ability of your blood, because the injections or the blood treatments that we use here, they all have the tendency to give you blood clots. So we always check this beforehand to make sure that if you need any injections along with that or any treatment along with that to make you prophylactic for the risk of the blood clot. And also all these bloods usually is being done on day 3. Sometimes we always do the day 21 progesterone to see for the ovulation, but this is not always done. AMH. So you might all have heard about AMH. So AMH is called anti-Mullerian hormone. So this is the most important hormone that tells us about your ovarian reserve, or in other words, tells us about the potential number of eggs that the ovaries have. It is a protein produced by the ovaries, which we detect in the blood sample. So it only gives us the information that is very important to know, that it only gives us an information about the number. It does not give us any information about the quality of the eggs. So AMH varies according to the age. So we always compare it according to the age. In some diseases like PCOS or the polycystic ovarian syndrome, the AMH is usually on a very higher side. It's usually more than 40. You can just see on the graph here. So this is the age and this is the value. So if we look into here, so this is the green phase tells you about the polycystic ovaries. So if the AMH for any age is more than 40, so that usually signifies that it might be a polycystic ovary. The normal range for the AMH for any age usually falls between 20 to 40. And if the AMH falls below 10, so that means you have a low ovarian reserve. And if you just see with the age, the AMH falls with the age. So that means that a woman with an age of more than 35 would be on the lower side for an AMH if you see into that graph. So ovarian reserve, as I already told you in the previous slide, it could be normal. So the normal could be between 10 to 30 and around 10 to 40. And the low is usually less than 10, which is a diminished ovarian reserve. And we have different treatment plans and different treatment protocols for that. And high, which is mainly more than 40, it usually signifies that it's a polycystic ovary. The second part for the female testing includes the anatomical testing. So that includes mainly four main things that we do. Most of the time, what we do here is SIS or HICOSI. This is called saline infusion sonogram. The second test that can be done for checking the tubes and the uterine cavity is hysterosalpingogram. So that gives us the anatomical shape, anatomical structure of the uterus, and also tells us if there's any abnormality with the tubes also. The third that can be done is laparoscopy. So laparoscopy is a keyhole procedure, but the only thing is that it has to be done under anesthesia. That can also give us an information about the tubes and around the surrounding pelvic area. And it can also give us information about other diseases like endometriosis and other scarring or adhesions from previous surgery. There can be different indications where we can use one of these tests depending upon your medical history and your previous investigations, like what investigation we can use to check for the anatomical testing. And the fourth is the hysteroscopy. So hysteroscopy is another procedure that has to be done under anesthesia, and that gives us again the information about the uterine cavity. It does not give us any information about the tubes. So if you just look into again here, the female anatomy that is important from the fertility point of view is that this is the uterus, this is the cavity. Here we have the cervix. These are the ovaries with the tubes and the femoral end of the tubes just sitting on top of the ovaries from where they collect the egg and they have to travel through the tubes to reach the cavity. And there they have to meet the sperm, which are introduced into the vagina. And there they have to meet an implant and make an embryo. So let's talk a little bit about SIS. As I told you that this is the investigation that we very commonly offer here. So it is called saline infusion sonography. It's a very simple procedure. It takes place in two steps. The first part is a simple internal scan or a vaginal scan that gives us an information about the uterus and the ovaries, where we measure the follicle count for the ovaries and we see if there's any ovarian cyst. So that gives us information about both the uterus and the ovaries at the same time. Takes about 10 minutes. It's a day case procedure. It's usually very well tolerated. The second part of the procedure is very simple. It's just related to the smear test. We put a small speculum and a small catheter is introduced through the vagina, through the cervix, and it goes into the cavity. We fill it with a small bit of saline and it fills the cavity, gives us the shape of the cavity to see if there's any polyp. And then the same solution gives us information about the tubes also. We see it's still on both sides to tell you exactly whether your tubes are open or not. These are a few other investigations that we offer sometimes depending upon the medical history. These are not offered to everybody, but this is the few fancy investigations that we can offer depending upon your previous medical history, the previous investigations that you have done, previous treatment you have, if you have got any. So these include mainly the immune testing. So immune testing can be done in two ways. One is by the blood sample, and other is by taking a small biopsy of your uterine sampling. One is called the Chicago bloods or the zip testing that gives us information about the natural killer cells, the T helper cells, the inflammatory environment of your blood type. And the second thing that we can test is by the uterine biopsy. It's a day-case procedure. We call you in, we get a small bit of sample by introducing a small catheter in, and we do the biopsy. The results usually come back in about 2 weeks' time, and we give you a call back to let you know about the results. The third is the autoimmune testing. Again, it depends on what your medical history is. The third is the recurrent miscarriage investigations, which include testing for a few antibodies. It includes testing for your karyotype, and it also includes testing for a few other hormonal profiles. The endometrial function testing is another testing that is called also as ERA. It tells us about the exact day or the exact receptivity day for the implantation or for the transfer day that we need to decide about you. And the final is the genetic testing. So that again depends if you have any previous history for any genetic abnormalities, if you have any previous child with any problems like that, or if you have family history suggested for that. So what you can do simply right now at the moment. So what if you're planning to go for a fertility checkup, or if you're planning to get pregnant over the next period of years, or you are thinking about that, what you can do at the moment. The most important thing is that we all have to have a very balanced and healthy lifestyle. It helps us in all ways, not only in fertility, but it also helps in maintaining a general health and well-being. So smoking has a very bad impact on both the egg quality and the sperm quality. So we should always try to quit smoking preferably. Alcohol and coffee, minimal alcohol intake, minimal coffee intake. You should have a healthy exercise routine. You should do regular exercise at least 30 minutes a day for at least 5 days a week. Stress, we all are living in a situation, living in an environment, especially these days. Stress is just like inevitable, but just try to make sure that you get any routine like that that helps you calm down and that helps you relieve with that. Weight again is a very important factor, no matter you are trying for a pregnancy, and once you get pregnant, also it has very important implications and very significant implications on your pregnancy outcome, your labor outcome, and your general health. So your BMI preferably should always be less than 25, and we should always make sure that we do our own efforts to make sure that we have the BMI in a specified range. So treatment. So what are the treatment options that we have? So it largely depends on the cause, as we already decided, discussed that we have different factors for the problems that we are having. It could be a male factor, it could be a male by female factor, it could be a combination of that. And depending upon all that causes, we decide that, okay, what is the treatment plan that we can decide for you. So these are the few treatment options that we offer here. If you talk see about the first one, this is called ovulation induction and the time sexual intercourse. Then we have IUI, or we call it as intrauterine insemination. We have IVF and ICSI with or without pre-genetic screening. You can also have the egg freezing option to discuss here. We have the donor egg program. We have the donor sperm double donation and shared motherhood programs with us. And also, we can also have the surgical sperm retrieval procedure here. This is usually recommended for those couples who have problems with the semen sample, who have no semen, who no sperms on the semen sample. So most of all, it is done directly by giving a small incision on the testes to get the sperm retrieval directly from the testes. And also, we can have the miscarriage management also. So let's talk about the TSI first, or the time sexual intercourse. So what does it mean is, so by time sexual intercourse, this is most important for those couples who have problems, who have mainly the irregular periods. So when you have the irregular periods, you do not exactly know about your day of ovulation. So this is most beneficial for those couples who have irregular periods. So what we do here is we plan your cycle yourself, and we monitor you, we monitor the growth of the follicles, and we tell you exactly that this is the time that you should take the trigger injection, we make sure that you ovulate on specified days, and we make sure that your egg is ovulated, and we tell you that this is the time to do the intercourse, and then that increases your success of having a pregnancy. It has a success rate of about 17 to 20% roughly, and mainly recommended for the younger couples. And especially if your fertility duration is not of a longer duration, then it's a better option to start with for your treatment. So the second thing that I'm going to talk about is IUI. This is called intrauterine insemination. It has a success rate of about 23 to 30%. We normally offer this procedure in a cycle of 3 cycles. It's mainly good for the couples who are looking for a reproductive choice for the same-sex couples, and it's also a good option for those in which there's a slight male factor abnormality. They can also have a benefit from that because by preparing a semen sample from IUI, we can just improve a bit of a sample there, and you can have an increased success of having a pregnancy with that. These are all medicated cycles, so that means we always give you the injections and the treatment for stimulating your ovaries. And once the ovaries are stimulated, we make sure that your egg is released and we inseminate the next in 24 hours. It's a very good procedure for a donor sperm if somebody is looking for that option. So if you just see the picture here, so that's the cervix, that's the uterine cavity. So what we do is a very, very fine catheter goes through the cervix with a syringe attached to it. The syringe contains the semen sample, and once the catheter reaches the cavity, you slightly push the semen and it just goes in. It's a very, very simple procedure. It's a day-case procedure. You're fully awake during this. It's a very comfortable procedure to have it. So now we talk about IVF. So IVF, what it means by in vitro fertilization, it has a maximized success in the minimum time. So this is most beneficial for those couples who have been trying to conceive for a period of time and they want to have a success in a minimum period of time now with a maximum success. And also who have a combination of both the factors like the female factor and the male factor abnormality, they usually have better success with IVF rather than the other methods. What is the diagnostic benefit mainly? So what we do in IVF is we are looking at the egg and the sperm at a very minute details. So we can tell you exactly that what might be the reason of you not getting pregnant. So we can have a look at the egg quality and we can decide about that what is the embryo quality there, and we can decide what is the good quality embryo, and we can prefer to transfer the best quality embryo for you to maximize the chances of pregnancy. So we will just go through in shortly that what are the steps involved in vitro fertilization or IVF. So the first step for IVF is the egg production. So we stimulate your ovaries by hormone therapy, and we stimulate the ovaries to make sure that we get the maximum number of follicles stimulated to produce the eggs. The second step is the egg retrieval or the egg collection from the ovary. So you go from stage 1 to stage 2, you take the injections during this whole phase. We track your cycles by means of scans, and once we see that yes, your follicles have reached a certain size, we give you a trigger injection, and then we call you for an egg collection. This is the time when we do the egg collection. It's a day-case procedure that has to be done under sedation. So once we decide when we collect the eggs, we need a sperm sample that is given on the same day, and we make sure that the eggs and the sperm meet together and they allow fertilization. So they fertilize together, stay in the incubator for a certain period of time, which is specialized incubator, and then we keep them there for another 4 or 5 days to make sure that we grow the embryos. So the embryos go through different phases of division from 2 cell to maximum cell stage, and then finally we make an embryo, and the embryo is transferred then by a simple procedure of an embryo transfer by small catheter going in, and we push the embryo into the cavity. So that's mainly a 5 or 6 step. It looks very simple here, but it's not. So we will just discuss in detail that what are the steps included in that. So as I talked earlier, so this is the egg collection. So day 1 is the growth, or day 1 is the day when the embryologist will give us the details about the fertilization of the eggs we have collected, and then they make them grow over a period of 5 or 6 days, and then we get the results for the embryo. So in a day 2 or 3 growth, the embryo reaches to a stage of about 8 to 10 cells. That's the maximum growth that it reaches. and then it reaches to the day 5. Here you can see that the embryo is growing in. It divides into 2 cells, then it reaches into 2 days into 4 cells, and then a 3-day stage it reaches to about 8 cell stage. And then around day 5, it reaches to a stage which we call as an early blastocyst, which is a good developed embryo. It has 3 main parts. It develops into a maximum of about 100 cells around day 5, which is a good quality embryo. And then we plan your transfer, which is usually around day 5. So talking about the success rates, which is very important. So if we just look at the graph here, so these are the results from our 2018 cycle, which are the fresh and the frozen cycles. So the blue one is the fresh cycles, and the purple ones are the frozen cycles. So if you can see, the success rates for the IVF is actually related again to the age factor. So as I told earlier that age is a very important factor in determining the fertility potential and also determine the success of fertility treatments also. And it also has impact on your pregnancy outcome also. So if you see that the women aged less than 35, the fresh transfer has a success rate of around 51.3%. And if you see around the age of 40, it's around 25.8%. So it's nearly about half to that. So what is IVF? So it has a maximized success in the minimum time, but we all know that it's a harder treatment plan, both from different aspects. So what is PGS? So what we mean by PGS is that PGS is called pre-implantation genetic screening. It is not offered to all the couples here. It is only reserved for certain couples who have certain medical history that suggests that we should go for that. So what it does is it tests embryos as the blastocyst stage for the chromosomal complement mainly, and it allows for the better selection of the embryos which have normal genetic makeup. So we normally do PGS and we normally suggest PGS for those couples who have a history of recurrent miscarriage, who has a previous history of recurrent implantations failure, who had multiple implantations done, but they have failed implantations. So these are the candidates suitable for PGS, so they can have added benefit or added value from this procedure. So I'll just talk shortly about what do we mean by egg freezing. So egg freezing these days is very common, and I think it's used by most of the women these days because these are different times we are living in. So most of the women actually decide to go for a pregnancy or having a first child after 35 years of age. That is what we are witnessing these days. So what they do is, as we have discussed that the fertility potential or the ovarian reserve decreases with the age. So fertility preservation is one of the options for those women who decide to have a first child or have the first pregnancy later on in their life or after their careers and all. So they can have an option of freezing their eggs at a younger age and using their eggs later on whenever they want to have pregnancy. So I would suggest that egg freezing is a good option mainly for the younger women who are less than 35 years of age, so they can go ahead for that. And it is kind of an insurance policy for them so that they can use their eggs of the same younger age, even when they want to get pregnant on a later age. So that is a very good option for that. So what are the implications of the IVF treatment, which or the any fertility treatment that you go through that? So most of important among them is the IVF, which is the maximum implications you have both from the financial point of view. You have physical burden, taking all the medications for a period of time, and then you have to go through different procedures, including the collection, the transfers, the investigations. It also has a very, very important emotional impact because you have to go through all that stress itself. Then you have to deal with it, the family and the friends and your workplace. You have to attend for the appointments. So you have to go through all emotional things going on during your IVF cycle and or your treatment cycle for any fertility treatment. Again, when we talk about emotional, it's a very important impact on your psychological aspects. So we always suggest that if you need to talk more, if you need to talk, you need counseling, or if you need to have more conversations, you should always do that and keep in touch with us because the more you talk, the more you converse. I think that makes it more easier for you to go through all those. So if we talk about the physical ones, so these are injections, then you have to go through the treatments for the, if unfortunately it ended up in a miscarriage, or if it ended up in a topic, or unfortunately if the things happen to a chromosomal abnormality, then you have to deal with all those physical burden. There can be a risk of twins and multiples also if you go through IVF cycle, or if you go through an IUI cycle sometimes. There can be a risk of hyperstimulation syndrome also, which is a combination of abdominal pain and you have bloating, and sometimes there's a cancellation risk also with hyperstimulation. So that is one of the physical burdens that you can go through. Then egg collection, as I talked earlier, it's a day case procedure. It's a kind of a surgery. It's not full anesthesia, but it's just sedation. But still, it's a physical process that you have to go through for that. So for the emotional and psychological impact, this is very, very important aspect for that, because it is the one that you have to go through the most. It's the hardest and the highest cost procedure, which is IVF. So definitely a good support from your family, from your partner, from your team, from your clinical team. This is very, very important. And you need to know that you can talk about it, and you can get all support from your clinical team. So this is very important before you choose for any IVF cycle to go through. So nutshell is a thing that most of the couples who do IVF will succeed. So most of the time we tell about it, the success usually is over a period of at least 2 or 3 IVF cycles, and finally most of the couples do succeed in having a pregnancy. So, what are the basic things that we see that most of the couples who are successful, they need to be determined. So, this is very important, that this is a positive attitude, that you will definitely get there, and you will get to that position which we are all working hard for. Flexible means that sometimes, as I already told, that the cycles could be a bit more erratic. They could be like hyper response or low response, and you always decide on according to the patient benefit what is best for you. So there can be a cancellation of the cycle depending upon that what is the current situation of your cycle. So it has to be flexible in that way. Emotionally resilient is very important because it has a very, very important uh, trauma or kind of a emotional burden on you. So it's very important that you should be strong in that point of view, and emotional survival is the key to success. So that's the most important thing that we have to talk about. So for that matter, it's the positive attitude that is really important to get into there. So thank you so much for all of your time here. So I have discussed very shortly and touched very basics to all the things here. And I will just go back to there if you have any questions there. So I will just talk about that. Thank you so much. Okay, so I will just tell one more thing here before I go ahead to the question and answer session. So first thing first is that the egg donor and the double donation programs are currently suspended here. That's why I have not talked in more detail about that, because the current program with some SIMS is suspended. So that's why we will not talk in detail about that, but we will get back to you once we get it sorted. Everything will be updated on the website, and we will be emailed everything about that. So transportation during pandemic is a very, very contributing factor. So this is the most important thing that is just taking a bit of time. So that's why it's just taking some time for that. Okay. So question and answer. Okay, so I've got a question here. So that do you prefer to use subcutaneous, intramuscular, or vaginal progesterone supplementation, and what dose times per day would you normally prescribe? So it all depends. It all depends on your cycle, how is it going on, and on your previous history also, that how you have responded to the previous progesterone that you have used. So most of the time we use for the vaginal progesterones that has a very good impact, and they do not make any difference in fact. But most of the time we use a combination for these if your previous response to progesterone has not been better. So it's only to use a combination of these to make sure that your lining gets better with that. That's why it all depends on what your previous cycle effect was. So that all depends on that. Then the second question is, does higher dose of stems affect egg quality? Okay, so again, I would just say here that the dose for the stimulation depends on what is your AMH level or your ovarian reserve level. So we always recommend to start with the lowest dose. If your AMH levels or the ovarian reserve levels are within the normal limits, it's always preferable to use with the smallest dose possible. And if you have a low reserve, then it's definitely a best idea to use the highest number of dose that we can use. And then I have a third question. There's a cycle limit on ovulation induction and time sexual intercourse. Yes, I would always say that the cycle limit would be not more than 3 for ovulation induction and TSIs. And for IUI also, I would say that the cycle limit should be around 2, not more than that, because IUI, with the first 2 cycles, they can give you an idea that how your ovaries are responding. And once you have not got a good response for the first 2 cycles, I would say you should prefer to go ahead with an IVF for the third cycle rather than going for the third IUI. In general terms, it's worthwhile trying IVF if you own eggs at 43, or you're better off proceeding directly to a donor option. At the age of 43, it all depends again on your AMH levels, that what is your levels for the ovarian reserve. If they are good, you can go for first cycle, but if it's not giving you a good result with your previous cycle with egg quality, I would say preferably to go for a donor option. Will high homocysteine levels affect IVF? So there is not recommended any evidence-based results for the homocysteine, so I cannot give you an answer that there is any effect for that. So for the semen sample, if all the 3 parameters are abnormal, including the motility, morphology, and count, I would say you can give it a try for having a supplement for about 3 months. But if all the 3 parameters are abnormal, so this is a very suboptimal sample and very less likely that it will improve. I would say that preferably proceed to the IVF treatment as soon as possible. So I'm just selecting actually just the questions which I can answer at this time, but some of these are very personalized questions which I'm not able to answer at the moment because it all depends on your previous treatments and everything. So I do not have all the information, so I'm not going to answer these questions. So I will just answer in general if it's there. Okay. So if motility is low, is it still well? Yes, if motility is low, but it should not be to a certain level. If the motility is very low, that is less than 20%, I would say it's not worth trying IUI because it will not be a good sample for the IUI even. So because for the IUI also you need at least a motility of 10%, otherwise it will not be worth trying IUI. So roughly an IVF cycle takes place in about maximum to about 6 weeks. So that's the whole that it runs around your menstrual cycle. The longest cycle takes about 6 weeks. So for a 39-year-old with a history of endometriosis and PCOS, a single female, I would recommend IVF with the donor sperm. I would not recommend IUI because that will not increase your chances. And I would recommend a double embryo transfer if you reach to a good quality 2 embryo stage. So that would be a good option. So ultrasound is a standard check for the female fertility testing because that's very important to see, look into your uterus and the ovaries. So I will say this is a standard to check for all patients coming to up. There's no recommendation for anything or specified indication for ultrasound check. There is no test for an egg quality. There's a question here. There is an egg quality test. There is no test to check the egg quality unless you do the IVF and we get to see the eggs under the microscope. That's the only way that we can check for the egg quality. So it's another question with older age. Let's say after 35, it is difficult to determine PCOS. It's not difficult to determine PCOS after 35. It can always be detected by your follicle count, by your blood levels, and by your ultrasound picture. We can always detect PCOS. And do PCOS have more eggs? So what happens in PCOS is that the eggs are there, but they're not ovulated. So it affects the quality of the eggs mainly. You can have more eggs, but it all depends on the quality of the eggs and the maturity of the eggs. So in PCOS, what the problem we face is about the quality and the maturity of eggs, not the number of eggs. Success levels higher on second cycle with blood thinners. So what the blood thinners do is they increase the blood supply to your reproductive tract. So it all depends what your first cycle has. If your first cycle has not responded well and they could find some abnormality, yes, the blood thinners can improve the chances and they can improve your chances with the second cycle. How long do you leave between the cycles? So I would say at least leave a 1 month natural period. So because if you get one natural period in between the cycles, your ovaries have just returned back to their normal state, and it's better results with the stimulation, and there are less chances of cancellation of cycles between them. So at least leave a month of natural periods between that. Maximum age for IVF to be in safe territory, I would say the maximum age would be not more than 40 to 43 years. What is number for social? So for egg freezing, I would say if your AMH count is between 10 to 20, that's a very good number to have a good reserve for freezing. So you have been trying to conceive since April. Good time to look for initial consultation. Yes, I would say just book for initial consultation. Human growth hormone help with egg numbers and subsequent. I have no experience of dealing with the human growth hormone, so I cannot give an idea about that. So there are a few questions about the cost, so my team will get back to you with that. So they will answer all your questions about that. There's another question about varicocele. So varicocele most of the time is diagnosed with a visual examination. And sometimes if it's still a chance, then the urologist person can give you a better idea about that. But sometimes it needs an ultrasound to make sure about the blood supply around that. That gives us a good idea about diagnosis. So if your AMH is 44 without PCOS, so that means that's a good number that you have. So formation concentrate time frame. There are a few questions about the time frame, so my team will get back to you about that also. So I'm not going to answer those questions here. There are a few supplements that you can take. Yes, there are good supplements like coenzyme Q10, vitamin C, vitamin D. There are a few other supplements like vitamin D and omega-3. They all have very good effects on egg quality and sperm quality both. So embryoscope has always been a part of IVF. Most of the time it is because it gives us a good images without any manual handling of the embryo. So it's always a part of our all IVF cycles here in Cork Clinic. So it is not that it is recommended for a few, it's done for all. Yeah. So I think that's fine. So these are all the questions that I can answer here at the moment. The rest of the questions, you can get all these answers from my team. Thank you so much for all of your time here. And I hope to talk to you again soon. Thank you so much. Bye.